Good evening, doctors. It's indeed a great pleasure to welcome you all this evening for this interesting discussion on the advances in statin therapy in CVD of Panacea in ACS and CCS with comorbidity. We are very grateful and delighted to have the faculties for today who are of international repute, and we are very grateful for them for their valuable time for today to share their valuable messages to us in this interesting topic. So we have, at the outset, I take this opportunity to welcome the moderator for today. Of course, sir, the contribution is immense in the field of cardiology. So I'm very delighted to welcome Dr. H.K. Chopra, who is a chief consultant cardiologist at MOOLCHAND Hospital, New Delhi. He is the national president of the Cardiology Society of India in 2015. He was also the national president of the Indian Academy of Echocardiography in 2017, a country head of the American Heart Association 2015 to 2019. He was also chief editor of the various textbooks in the field of cardiology, president, World Wellness Foundation, World Heart Academy, World Nutrition Academy. Sir was also bestowed as the icon of the century in clinical cardiology and echocardiography. And this honor was bestowed upon him by the Bharat Ratna, former President of India, Dr. A.P.J. Abdul Kalam. Sir has organized more than 2,200 workshops on public health education in the field of cardiology. He has more than 690 publications in various national interventional journals of cardiology. Dr. Chopra is also National Chief Advisor to the Tata Sky Family Channel. And recently, Sir was bestowed upon the Icon of Century in the field in clinical cardiology by the Minister of Health, Family Welfare, by the Minister of Science and Technology and Minister of Earth Sciences, Government of India, 2019. It's a great honor to have the selfless personality in the field of cardiology, Dr. H.K. Chopra, sir. And we are delighted to have welcome the other faculties also will be introduced by Dr. H.K. Chopra. Sir, over to you, sir.
Thank you very much, Johnny. Dear friends, ladies and gentlemen, it's really a great pleasure and honor indeed to be here this evening on the platform of national webinar being organized by IPCA on advances in statin therapy in CVD, in ACS, CCS, and various other vascular disorders with and without comorbidity. I welcome you all, especially the faculty of a very high magnitude before us, including Professor C.N. Manjunath, Dr. Tani Nair, and Dr. A.K. Pancholia. You all know that India is the world capital of diabetes, hypertension, coronary artery disease, and now peripheral vascular disease, as well as dyslipidemia. If you see the details of various vascular disorders, this is all because of oxidative stress of lipids, which is a very, very important factor responsible for endothelial dysfunction. So what is our main theme this time in the webinar? The theme is we talk on the lipid lowering efficacy, safety, and potential of various statins. We also like to discuss on anti-thrombotic potential and anti-inflammatory potential, as we have the most powerful faculty with us, and come to crystalline some kind of guidelines for practical application in our day-to-day practice. We also want to discuss about the vascular potential power of statins. Where are we? Whether they are micro vessels or medium-sized vessels or large vessels. I think all this need to be addressed today, and it is going to be very, very powerful. And out of all this, the most important is what is the power so far as the morbidity and mortality reduction of statin is concerned, whether it's ACS or CCS. Now, what is the agenda? It's very well known to you. Our first speaker, Dr. Tiny Nair, covering on remnant cholesterol, usefulness in clinical practice, then statins and ACS by Professor Manjunath, and statin intolerance, is it really a problem, by Dr. A.K. Pancholia. Our academic partner is IPCA Laboratories. Now, to introduce the speakers is a Herculean task. It's not easy because all the speakers are par excellence. They are great researcher, great orator, and they are par excellence in every spectrum of cardiology. And they are the face of India in the world. We are very proud to have Dr. C.N. Manjunath with us, who is the professor and director of Shri Jayadeva Institute of Cardiovascular Sciences and Research, Bengaluru, and a past president of Indian College of Cardiology. Our first speaker is Dr. Tiny Nair, who is a very eminent person. He is head and chief consultant, Department of Cardiology, PRS Hospital, Trivandrum. As I mentioned to you, his orational skill is exemplary. Dr. A.K. Pancholia, he is HOD and clinical and preventive cardiology in Arihant Hospital, Indore. He has a tremendous academic potential and has been a very hard-working and a very great orator. These are all very eminent personalities before us. Without wasting any time, I will request our first speaker, Dr. Tiny Nair, to have his presentation. Dr. Tiny Nair, sir.
Thank you, Professor Chopra, for that nice introduction and calling me among all the eminent speakers in India to talk about this. Give me a moment's time by the time I share the screen. You know, many of you might be wondering as to why we are talking about remnant cholesterol, something so very vague. We hear about it in academic circles in a talk which is purely clinical, advances in statin therapy in cardiovascular disease. Now the whole idea is we know that we would like to know that despite statin therapy, a lot of patients have a residual risk inbuilt in them. And we have quite a few markers of talking about them. And how useful is this remnant cholesterol, which we always feel that something academic in the textbooks, in our practical day-to-day management of patient tomorrow. And that is why I thought of when Dr. Chopra gave me a free hand that you can include anything, I thought we would talk about the remnant cholesterol. So a little bit of a recap of what we already know. This is what we all of us know, that if we look into the lipid profile report coming from any lab to us, to a physician, we see that we have components of the lipids. We would get a report of high density lipoprotein, HDL, we get an LDL, we get triglyceride and total cholesterol. So this is that all we get as a report from the lab. And we are aware that we have been taught right from our graduation classes that LDL cholesterol is the villain, is the bad factor. The LDL cholesterol percolates through the endothelium, sets up the process of atherosclerosis, accentuates it, and kind of partly responsible for the acute coronary syndrome that results. So LDL is the culprit. And we know today that we have very powerful agents, to start with statins, that tend to lower LDL, and that is how statins have its preventive effects. So the villain is LDL, and statins tend to reduce LDL. Now, if we go a little more further, one more step, we understand that all these fats, LDL, HDL, cholesterol, triglyceride, they are all fats. So they cannot circulate. They cannot circulate in the blood as liquids. So they are packed inside globules so that they can travel. So if we take one of those blobs, one of the globules of LDL particle and cut it open, right? LDL cut open, we see that it contains so many chemical things. One of that is, of course, inside the LDL, we have the triglyceride, which you see as a blob with a tail, that is a triglyceride. And of course, those yellow pentagons, hexagons, which are basically cholesterol esters. So inside the LDL, we have triglyceride and cholesterol ester fat. And that's why they're there. They're taking all this fat to the tissue, right? And this is surrounded by a lipophilic hydrophilic membrane, so that, you know, outside it is hydrophilic, so that it can go in the blood, and inside it is lipophilic, keeping the lipids inside. This membrane surrounds the LDL molecule. But funny enough, in that membrane, we see that there is something jutting out, and that is blue. And that blue is what we call as apoprotein or apolipoprotein. For LDL, it is ApoB, right? So we have ApoA, we have ApoB. So for some time, we thought that this is just like a label on a package. So if we take that blue and read, where is this going? Oh, this is ApoB. So it's going to the tissues. It is LDL. It's just a label on the package, the Amazon package that you get, right? But today we know it is far more than just a label on the package. It tells us what is inside the package. It tells us the genetic background of how it is manufactured, and a lot more things about LDL beyond just looking at the LDL. And that is the apolipoprotein. Now, if we look at the trials of statins, okay, we have trials, we have looked into, this graph shows all the trials. The x-axis is the mean LDL level in millimoles. So you see it starts from about 1.8, which is about 70, and goes up and all that. And all on the y-axis, we have the coronary heart disease. So event rate in y-axis and the LDL in x-axis in millimoles. Now, if you look at that, there's a secondary prevention trial. We have diabetic secondary prevention trial. We have diabetic primary prevention trial. We have ordinary primary prevention trial. In every kind of trial, statins have shown that there is progressive reduction of coronary event rate. So no doubt, diabetes, no diabetes, primary prevention, secondary prevention, statins are helpful. And not just that, if we take those lines and look at where it touches the baseline, which means beyond that we may not get a benefit. We know that it is about 1.8, which translates to LDL of 70 mg/%. So we said initially that you bring down your cholesterol level, LDL levels to at least 70 or below to keep the risk at minimum. That not just 100 or even 130 as we thought in the past. Now, despite that, if we look into important trials, for example, on the left set of bars, it is PROVE-IT-TIMI-22. Now, PROVE-IT-TIMI-22 trial was done with acute coronary syndromes, intensive lipid therapy, lipid lowering by statins versus standard therapy. We see that there is good benefit, right? 26 to 22. So absolute risk reduction of 4%. But look at that orange bar. Despite statin therapy, there is significantly residual risk still remaining. Okay, take a trial like TNT, where we looked into stable coronary artery disease. Right, the whole cardiovascular incidence is low, but still, and we benefited. But in the orange bar, still we have about 9% residual risk. So whether we talk about acute coronary syndrome, which is high risk, or standard chronic coronary artery syndrome or chronic stable angina, we have a residual risk despite intensive statin therapy. So the idea is, how can we identify them? So the ways of identifying would be an expanded lipid profile, right? We look into things beyond LDL. We started looking into non-HDL cholesterol, which is total cholesterol minus HDL, so that we get all the bad stuff there. We started looking into what is called the ApoB or the ApoB-A1 ratio, where we looked at that APO and try to tell that what kind of bad things are. There's a better marker than looking at LDL alone. We started looking at what is called LP-little-a. LP-little-a is one of those apolipoproteins linked on to fibrinogen. So we thought there's a link between thrombosis and lipids, LP-little-a. We looked at what is called an LDL particle size. We hypothesized and proven, of course, that smaller the LDL, they are more toxic. They can escape through the endothelium and set up more vascular inflammation and result in more atherosclerosis. So smaller the LDL size, the worse, more LP-little-a, more ApoB. But as you can understand, ApoB, LP-little-a, LDL particle size are all expensive. Okay, you might get it done in hospitals of the experts sitting here, but for the large volume of people going to an ordinary primary or secondary care center all over the country, these are expensive. You can't do it. You can't look at all this to predict the patient outcome. So with that view, let us learn about the new risk marker of remnant cholesterol. And as we would see that estimating remnant cholesterol, you don't need anything. All you need is a clearer understanding of the same lipid profile report that you have with you. Now, to understand remnant cholesterol, we should know a little bit of the pathophysiology or the biochemistry of how lipids are metabolized. This may look complex, but it's pretty simple. Let us spend just about 5 minutes from this picture, which is adopted from the Journal of American College of Cardiology, which came in 2018. Now we know that the source of cholesterol, whatever, LDL, everything, okay, comes from either food or is manufactured in the body from the liver. So we have just two sources. On the left, you see the intestine, and in the center, you see liver. So fat are coming from only two sources. So if we take the intestinal source on the left, the particle that comes in after absorption is chylomicron, right? Chylomicron, it's a large molecule. We call it the source lipid molecule, source molecule. And that chylomicron over time is metabolized by a lipoprotein lipase and becomes smaller and smaller and smaller. So a big molecule, a big particle becomes smaller, smaller and smaller, and then it goes to the tissues. So the scheme is simple. Now, if you look at the intrinsic formulation of cholesterol, it looks complex, but the same pattern. Forget about the complexity. The liver produces again a particle which is exactly similar to chylomicron, a very large density lipoprotein, VLDL. Okay, and that, if you see, these two are the source particles. So source particle from diet is chylomicron, source particle from liver is VLDL. Now the next step is the source particle from food, chylomicron, as you can see, the red arrow becomes a remnant particle by lipoprotein lipase, a smaller particle, remnant particle, right? And the intrinsically manufactured VLDL also becomes a smaller remnant particle. It is much later that that remnant particle gets converted to LDL, and we just are focusing on LDL. So all these years, we were not focusing on a remnant particle. The remnant particles are a one-step metabolized particle coming from chylomicron or VLDL. So if we take the remnant particles, they are, see, chylomicrons are large. They can't really enter the endothelium, cross the endothelium. But remnant particles are smaller. So all these years, we were neglecting the remnant particles and looking only at the LDL. So let us come down to the practical lipid profile picture that is given to us, right? So this, as you can see, that dark line in the center, above that is blood, below that is intima, media, adventitia. So below is intima, media, adventitia, the arterial wall, and above is the lumen. So on the left, you have chylomicron, you can see there, and on the right, you have HDL, right? So HDL is there. We know HDL is good. HDL tries to take out cholesterol, reverse transferase, and bring it down to liver for metabolism. And of course, on the left, you have chylomicron. Chylomicron is so large that it gives rise to all the other smaller molecules, but it doesn't by itself cross the endothelium. It is large, right? So let us eliminate chylomicron. So we are left with VLDL, chylomicron remnant, IDL, LDL, and HDL. Now, if we take out the HDL from the lipid profile calculation, we get a benefit of getting information far more than LDL. So you have LDL there, the red box, and the remnants there. So when we are talking about total cholesterol minus HDL, or the concept of non-HDL cholesterol, understand that. We are talking about non-HDL cholesterol. All we are doing is taking out that HDL from this calculation. So non-HDL cholesterol actually is LDL and the remnants, so the bad fellows. Now, if we take out that LDL also from this calculation, LDL also, that means total cholesterol minus HDL minus LDL, you get the remnant cholesterol. So that is remnant cholesterol. So one easy way of calculating remnant cholesterol is total cholesterol minus LDL minus HDL, provided your LDL is a direct measured LDL rather than a calculated LDL, right? So total cholesterol minus LDL minus HDL gives you remnant cholesterol. Now with that idea, we should really see, is this so important? Is this so important? Now this is a 110,000 patient population study where the endpoint was looking at myocardial infarctions and ischemic strokes. And in this study, they had about 2,973 events. And they tried to see the predictive value, as you can see there, of LP-little, non-HDL cholesterol, LDL cholesterol, and remnant cholesterol, trying to see which is better in predicting our mortality over a 5-year period. And you see that remnant cholesterol, very clearly, the remnant particles stand at the most powerful, as a most powerful predictor of event rate compared to LP-little, non-HDL cholesterol, and LDL cholesterol. So remnants are to be calculated and brought into clinical purview. Now, this is data that came from Copenhagen, came about 2 years back in JACC, the remnant cholesterol as a risk factor for ischemic heart disease. And what they found is a large trial, as you can see there, so about 73,513 subject database, about 11,000 had ischemic heart disease. You look at that. It looks complex, but that's simplified. On top, you have remnant cholesterol, that red box. And at the bottom, you have LDL cholesterol. These are all levels. So LDL cholesterol, you have the second column is milligram percent, 90 to 110, 115 to 135, and more than that. Let us take the LDL's maximum level. If you take the maximum level of LDL, which is more than 160, the predictability of ischemic heart disease is hazard ratio is 1.8, right? But if you take the highest quartile of or pentile of remnant cholesterol, you see that the predictive value is 2.3, far more than LDL. And that is why we had always been saying that remnant cholesterol is a far higher predictor, far better, more sensitive predictor of ischemic heart disease in the future compared to LDL or any other parameter that we get. Now, when we talk about remnant cholesterol, we say that if the remnant cholesterol is roughly more than 40 milligram percent, if it is more than 40 milligram percent, it is associated with a 2.8-fold increase in cardiovascular event rate. So simple, if it is more than 40, you have a 2.8-fold increase in cardiovascular event rate. This is the chart that is shown, generally said that if you have a remnant cholesterol level of less than 15 or 0.4 millimoles per liter, there's very little risk. Low risk is 15 to 23, 23 to 27 low medium, 27 to 42 high medium risk, and more than 42 is high risk. But these are all numbers, but basically to remember, anything above 40 is significantly high risk of coronary events. Now we have already learned that we can measure remnant cholesterol by total cholesterol minus HDL minus LDL, provided LDL cholesterol is direct and not calculated, right? That is one. But there are other novel ways, right? Looking at the lipid profile report, where we can estimate, do my patient have a higher remnant cholesterol? And here is one unique way. See, if you look at that bar graph, the x-axis is triglyceride. Okay, this is again from a large cohort. So x-axis is triglyceride, less than 1 means 100 milligrams, and more than 5 is 500 milligram percent. So as this is in millimoles, so this is triglyceride in millimoles. On the right, as you go, it increases. The green color is HDL. The light brown is LDL, and the red is a remnant particle. So what do we see? We see that as we progressively, as there is increase in triglyceride, understand that, as there is increase in triglyceride and decrease in HDL green, you have more and more of remnant cholesterol. So I repeat, as we have progressive increase in triglyceride and a reduction of HDL, we have a higher or remnant cholesterol. So people started thinking that can we use this as an indirect evidence of remnant cholesterol? So if we take a triglyceride divided by HDL, and if that ratio is more than 4.5, that does indicate increased remnant cholesterol. So I repeat, first thing we learned is total cholesterol minus HDL minus LDL is remnant cholesterol. Second, take triglyceride, divide by HDL. If it is more than 4.5, it signifies increased remnant cholesterol. Right. Now, is there a proof? Yes, there is proof. For example, if you remember 2010 came the ACCORD study. That is in type 2 diabetes. They tried fenofibrate, addition of fibric acid derivative. And what was the result? The result was there is absolutely no benefit. So fibrates did not make an impact on stroke, MI, or any other endpoint, despite lowering triglyceride. Okay, but when they divided the group into those who had high triglyceride, low HDL, meaning a triglyceride HDL ratio of more than 4.5 on the left box, and the entire group on the right box, you see on the left box, there were about how many patients there were. This group consisted of about 7.6% of the total cohort, while 82% were on the right. So the left cohort, where we had a triglyceride HDL ratio of more than 4.5, we did see an event reduction by way of major fatal or non-fatal cardiovascular events were reduced. And it was significant, between 17.3 and 12.37. But in the entire cohort, fibrates did not produce an effect. And why the effect came is clearly because fibrates were able to lower the remnant cholesterol over and above the standard statin therapy. So where are we coming to? So the second way of estimating remnant cholesterol is looking at the TG-HDL ratio. Triglyceride HDL ratio is more than 4.5. It's an indirect indicator that there is elevated remnant cholesterol. Point number 2. Point number 3 is a more larger view. Understand that we were always thinking that HDL is good. Yes, HDL is good. HDL is a marker that a higher HDL is protective. So we were going after HDL. We were trying to manufacture artificial HDL, ApoA1 Milano. We tried to use drugs like torcetrapib, right? Now, torcetrapib drug very clearly showed that over atorvastatin, it significantly increased HDL, right? The HDL rise at about 75%. But what happened when we looked at the mortality result, we found that torcetrapib, which improved HDL so much, actually increased mortality, increased the event rate. So it failed. So over time, we have understood that HDL is just a marker of heart disease and not a target. So I repeat, HDL is a marker of vascular health and not a target, because by raising or lowering HDL, we are not gaining. But HDL very clearly tells us how is our vascular health. To understand that, there was a very interesting study that again came from Copenhagen, where they looked at a huge number of people and monitored their triglyceride and HDL in the long run. Very interesting, very interesting. This data, the Copenhagen General Population Study, had 108,731 patients. So what they did, well, there were two arms. One is a long-term result. In the long-term arm, very interesting, they looked at HDL and triglyceride over a long-term period, 10 years apart. So they looked at HDL and triglyceride. Now, 10 years later, they again measured. And then in a short-term arm, they did measure triglyceride and HDL after an oral fat loading. So they gave oral fat and measured what is the rise of triglyceride and what is the drop of HDL. And then ordinarily, they measured 10 years apart what is happening in the long run to HDL and triglyceride. And the results are very interesting. One, the long-term result. The long-term result, they found that HDL in the long term is a marker of triglyceride and remnant particle in the long run. So persons who had a very low HDL to start with, over time, they developed high triglyceride and high remnant particle. Okay, so long run, HDL determines remnant particle level 10 years later. And if that is so, we can clearly understand why HDL actually was a risk marker. But in the short term, when they gave that oral fat load, they found that triglyceride increased after a fat diet by 96%, right? Immediately after a fatty food. But HDL decreased only by 1%. So in the short term, HDL does not denote triglyceride at all. But long run, it very clearly tells us what is going to be this man's triglyceride and remnant particle in the long run. Right. So that is why I would rather say that HDL is the HbA1c of remnant cholesterol. So if you have somebody, a patient with a persistently significant low HDL, despite the fact that he doesn't smoke and he does regular exercise, he is a person who is likely to have a high remnant cholesterol. So, and low HDL is a long-term marker, like the HbA1c of blood sugar of remnant cholesterol. So, you know, this is one of my favorite anagrams. What does it say? You know, if you ask 10 people, 5 would say that what is written there is learn, L-E-A-R-N. Another 5 would say, no, it is teach, T-E-A-C-H. You can read it whichever way you learn, whichever way you look at it. So anagrams are like that. So I think these symposiums are important so that all of us, the listeners as well as we, learn as well as teach. And that's why I respect and appreciate so much Professor H.K. Chopra for organizing such meetings and letting us learn and teach. So what did we learn at the end? Residual risk prediction is important, and normally we resort to non-HDL cholesterol, ApoB, Lp(a), LDL particle size, which are expensive. So today we have a new concept of remnant cholesterol. We can estimate that simply by looking at total cholesterol minus HDL minus LDL, provided your LDL is a direct LDL and not a calculated LDL. Okay. Second thing, you can simply divide your triglyceride by 5. It will give you remnant cholesterol. But understand that this always may not be very true, especially if the triglyceride is very high or very low. Right. Point number 3, triglyceride HDL ratio. This thing is something that I think people don't commonly do and don't realize. A TG-HDL ratio more than 4.5 indicate that there is a possibility of high levels of remnant cholesterol. And finally, HDL by itself is a marker of long-term remnant cholesterol. If I see a patient today with a very low HDL, I should think that 10 years down the line is likely to have a higher level of remnant cholesterol. And all this, understand all this comes at no extra cost, right? So your patient has come sitting opposite your table with a lipid profile report. All these calculations you can do without spending extra rupee, right? So rather than going for Lp(a) or anything, you can have a concept as to how much of remnant cholesterol your patient has. So I repeat, as we end, total cholesterol minus HDL minus LDL gives you remnant cholesterol. Simpler way would be triglyceride by 5, you get remnant cholesterol. Triglyceride HDL ratio more than 4.5, high levels of remnant cholesterol, and average HDL in the long run predicts how much would be the remnant cholesterol. Lower the HDL, higher would be remnant cholesterol. Okay, and of course, all this comes at no extra cost. So thank you for your time and attention. I give the screen back to Dr. Chopra. Now, I have another symposium coming up right next. So if there are some questions, 1 or 2, Professor Chopra, I am ready to answer. Thank you, sir.
Thank you very much, Dr. Tata. It was a brilliant talk and something very new for us to learn as to how remnant cholesterol is responsible to one of the risk factors for the ischemic heart disease. It's a very, very brilliant talk. And you mentioned very nicely the relationship of total cholesterol and HDL and LDL. I think it was outstanding. If there are any questions in the audience, I'm sure, Johnny, you will note down. And then I think at the end, whatever best we can reply. Otherwise, we'll hand over the question to Dr. Tani Nair to give a reply to all this. I just have only one question, Dr. Tani Nair.
Yes, sir.
What is the best way to manage remnant cholesterol to reduce the risk and the event rate in the vascular problems?
See, I think right at the moment, all that we have would be a good lifestyle, including a good diet control, avoid smoking, regular exercise, and maintaining a good body weight. That would be point number one. And second thing is, all of us know that probably we should use statins. And we know that certain statins have more effect on remnant cholesterol, like rosuvastatin has a more effect on remnant cholesterol compared to atorvastatin. And we have, of course, the new drugs coming in, the PCSK9s, bumpedoic acid, we have the inclisiran, and we are yet to understand them fully because our experience with them are limited. And I'm sure that as time passes, we would have probably more and more armamentarium in our hand to treat remnant cholesterol as such. Does fibric acid help? I think fibric acid helps only in patients who are already on statins, and if you have a TG-HDL ratio of more than 4.5. I can see one question here in the chat box. Should statins be given to all hypertensive patients who has a little bit dyslipidemia? Yes, little bit dyslipidemia, yes. We now don't say little dyslipidemia, more dyslipidemia. We say that if the lipid levels are abnormal, you need to have statins on board. For every diabetic, we put them on statins. A hypertensive, if he has a significantly increased risk, 5-year risk, we would put them on a statin. That was the usual way. But only about 2 months back, the journal Circulation brought out a very new article where it's a concept article, but it covers on hypertension and statins, where they say that the effect of adrenergic hormones like norepinephrine on the vascular tree, the effect is reduced if you have statin on board. And that probably brings into your question answer that perhaps everybody with a higher risk, including a hypertensive, should be on a statin as a vascular protection.
Is there any reason, Tanina, that rosuvastatin is superior as compared to atorvastatin? Is there any reason or just a study?
No, so basically rosuvastatin's effect on lowering triglyceride is far more potent than any of the other statins. And because of that, see, it is the liver that manufactures VLDL, and that VLDL is what gives rise to the remnant particles. So we know that the effect of VLDL manufacture, the best is by inhibition would be by rosuvastatin. Unless we are talking about, we are also coupling in PCSK9 where we have a far better effect. Yes.
Thank you very much, Dr. Tanina. I think we are very grateful to you for your brilliant exposition. And with this, we go to Dr. Manjunath. Dr. Manjunath, unmute. I think I've already introduced Dr. Manjunath. He is also an orator par excellence, and his talk is very interesting because every one of us has interest in ACS and CCS, but his focus will be mostly on the ACS, and I'm sure we learned a lot as to what is the latest in the ACS management. Ladies and gentlemen, I present to you Professor C.N. Manjunath, Dr. Manjunath sir.
Yeah. At the outset, I'm very thankful to our chairperson, Dr. H.K. Chopra, and also my Dr. Tiny Nair, Dr. Pancholia, and also I really thank Deepka and Johnny for organizing this meeting and bringing all of us on this common platform. And already Dr. Tiny Nair has alluded to the importance of some remnant cholesterol, because it's a really thought-provoking talk. And in fact, every decade we are seeing something new in lipidology. That means there is something even beyond LDL cholesterol. We all know that LDL is a marker of vascular health as well as an important target for management of coronary artery disease. Now Dr. Tiny Nair has said there is something even beyond LDL cholesterol, that is remnant cholesterol. So there's an excellent information. So what is the importance of statins in acute coronary syndrome? Probably apart from interventions, the two wonder drugs that have revolutionized the practice, cardiovascular practice in the context of acute coronary syndrome or in coronary artery disease. One is statins, other is P2Y2 inhibitors. So these are the two wonder drugs that have played an important role and improved the outcome of patients with acute coronary syndrome. Sorry, this stuck. Okay, fine. So I will be talking about the importance of statins in acute coronary syndrome. The issue is what should be the dose of statins, whether it should be high intensity statin reduction, LDL reduction, and how long we should continue with this high dose statin in context of acute coronary syndrome. If you look at the burden of cardiovascular disease, definitely it is the leading cause of mortality globally. In India, annually, we record about close to 3 million deaths due to cardiovascular disease. Worldwide, it is close to 18 million deaths. And of the 60% of cardiovascular death is attributable to ischemic heart disease. If you look at the pattern of acute coronary syndrome, in the Western scenario, nearly 40% is non-ST elevation MI. But in Indian context, as per the GRACE registry, as well as for our own Indian data, nearly 60% will be ST elevation MI, while in the Western scenario, only 20% present with ST elevation MI. So that means in India, we see more often an ST elevation type of ACS, while in the Western scenario, it is nearly 70% is non-ST pattern, and of course 40% is about unstable angina. So what are the definitions of these three patterns of acute coronary syndrome? If patient has got chest pain and some subtle ECG changes, but if the troponin levels are normal, we label them as unstable angina. If patient has got ST depression or T-wave inversion with troponin leak, that is troponin elevation, we brand them as non-ST elevation MI, and ST elevation MI, of course, it's self-explanatory. That means there will be an ECG showing an ST elevation. If you look at the evolution of acute coronary syndrome, it is a continuous process. What really plays a significant role in the various pattern of acute coronary syndrome is the stability of the plaque, the morphology of the plaque. That is the one that mandates the particular type of acute coronary syndrome presentation. Because many times, yes, we do a treadmill test, and if it is negative, a negative treadmill does not rule out an atherosclerotic disease. It only rules out a blockage which is probably more than 70%. And even for that matter, stress thallium also has the same implication. Why I am emphasizing on this? This in our practice, we have seen, all of us have seen, treadmill done about a month back, then patient comes back after a month with the acute myocardial infarction. And the question is, my treadmill was negative about a month back. Why did I develop acute myocardial infarction now? Because as I already said, all this stress imaging only excludes a blockage of more than 70%. And because if you look at the angiographic background of acute coronary syndrome, and it is less significant lesions are more prone for acute myocardial infarction than severe obstructive lesion. So what determines the pattern of acute coronary syndrome, whether it is an ST elevation MI or whether it's a non-ST elevation MI, is the stability of the plaque. So in a stable angina, the plaque is stable, a stable plaque. In other words, it has a low, lipid core and a thick fibrous cap. So as a result, patient is stable. In ST elevation or in non-ST elevation MI, they have a plaque which is got a high lipid core and a very thin fibrous cap, and this is where all of a sudden plaque ruptures and a non-obstructive lesion becomes a total obstruction resulting in ST elevation MI, and a plaque rupture resulting in subtotal occlusion resulting in non-ST elevation MI. So the angiographic picture in an ST elevation MI, vessel is totally occluded. In a non-ST elevation MI, vessel is obstructed, no doubt, but still there is some flow. This is where statin plays a significant role, because what matters, the mandates the pattern of acute coronary syndrome, again, is stability of the plaque, and the plaque stabilization is one of the wonderful fundamental actions of statin. This is how its role is very important in a context of acute coronary syndrome. Many a time we do an angiogram and the blockage is just 30-40%. We are very casual. Some people are casual. No, nothing will happen. Your blockage is just 30%. You go home. So these are the people have to be protected with aspirin and statins, because sometimes when an unstable plaque ruptures, a so-called asymptomatic patient develops an acute coronary syndrome. So this is a vulnerable versus stable plaque. So vulnerable plaque, the whole objective of this statin therapy is to convert a vulnerable plaque into a stable plaque, and that's how the adverse events can be reduced. Most fatalities occur within the first 30 days after acute coronary syndrome. This is why there is a rationale behind high dose of statin. Number one, we have to give a high intensity statin therapy, and also it should be early also. Anything you do in acute coronary syndrome, it has to be early. Whether it is intervention, it should be early. Whether it is thrombolysis, it should be early. Whether it is your statin, it has to be early, because maximum number of deaths occur within the first 30 days. Hence, it has to be intensive and it has to be early, whether it is an unstable angina, whether it is an acute myocardial infarction, whether it is non-ST type of ACS. This is the vascular triad in pathophysiology of acute coronary syndrome. The most important platform on which atherosclerosis develops and the atherosclerotic events develop is endothelium. When there is an endothelial dysfunction, and also an acute coronary syndrome is a syndrome where there is a diffuse vascular inflammation of the coronary bed. Even if there is a LAD is the culprit vessel, there will be a vascular inflammation in circumflex also. So also in right coronary artery also. So there is an inflammation and immune activation, and it also stimulates platelet activation, aggregation, ultimately resulting in plaque rupture and a thrombotic occlusion. So this is how the pathophysiologic cascade of ACS goes. So endothelial dysfunction, reduction in nitric oxide release favors thrombosis and also causes vasoconstriction. It enhances the release of Van Willebrand factor and reduction in TPA, that is plasminogen activator to inhibitor ratio, and there is increased local expression of adhesive molecules on the endothelial surface, what is ICAM or VCAM. So there is a significant endothelial dysfunction. This is where statin significantly improves the endothelial function. As a result, there is a pro-vasodilatory mechanism within the vessel wall. So plaque ruptures, as already alluded to, in a context of an acute coronary syndrome, it's a milieu of a thrombotic state or a prothrombotic state with elevated fibrinogen and factor 7. There are increased levels of Van Willebrand factor as well as plasminogen activator inhibitor. There is reduced activity of plasminogen activator. So the management of acute coronary syndrome, we are well aware. Just to emphasize that oxygen should not be given for uncomplicated acute myocardial infarction, because unless the saturation, of course, we are in COVID time now. Anything below 94, we start giving oxygen. But particularly, if oxygen is given in excess or without justification, it releases free radicals and can be hazardous. It can cause vasoconstriction, increases the afterload. Only oxygen should be given if there is desaturation or in pulmonary edema or cardiogenic shock. This is just out of clinical interest I am alluding to. And all those therapies, and a word about morphine. Morphine should not be given for patients with inferior or RVMI because it reduces preload. And of course, it is a choice for anti-wall MI and antiplatelet therapy, because we always today in our practice, in everybody's physician or cardiologist treating this thing, we are giving a cocktail of 3 drugs when a patient present with ACS, that is aspirin, that is P2Y2, preferably clopidogrel, and high dose statin, either 80 milligram of atorvastatin or 40 milligram of rosuvastatin, forms a cocktail at the time of presentation of ACS patients. and disease modifying therapy. Under disease modifying therapy, we have statin as well as ACE inhibitors. And of course, just updated information, I mean, just reminding aspirin, the first dose of aspirin should be high, that is at least 325 milligram. Then subsequently, it is reduced from day 2 onwards, 150 milligram, because on day 1 of ACS, we need a faster action of aspirin, hence the dose has to be 325 milligram on day 1 of ACS. So the benefit of lipid lowering, lower the better. So this is one situation where if there is a linear correlation between reduction in LDL and reduction in various adverse vascular events. Look at this particular diagram here. As there is a reduction in LDL cholesterol, and there is linearly there is reduction in adverse cardiovascular events on all these trials. There are nearly 1 dozen trials. The bottom line conclusion of all this trial is as LDL starts dropping, there is also a linear reduction in LDL, vascular events. So the benefits of statin in acute coronary syndrome, it improves vascular endothelial function. It attenuates vascular inflammation, and it stabilizes the plaque, reduces platelet activation and thrombus formation, and influence the myocardial protection and remodeling. So these are the potential benefits of statin. So statin is not just a cholesterol lowering drug. It has got an anti-inflammatory effect. It has got a modest anti-platelet effect. And also because in treating acute coronary syndrome, it's not just enough if the epicardial flow improves. It is also essential that myocardial flow also should improve. So that is where endothelial function plays an important role, or the microvascular dysfunction plays an important role. So it has multiple benefits. In fact, interestingly, we have seen some patients of ischemic heart disease, ACS patients, where ESR is high. After high dose statin, ESR comes down, because ESR is also a marker, like a CRP. So they are also a biomarker of inflammation. So there, because atherosclerosis is not just lipid deposition or platelet activation aggregation in the vessel wall, it's also a non-infective inflammatory pathology within the blood vessels. So statin has got both a lipid lowering effect, also has got an anti-inflammatory effect. That what we call it as pleiotropic effect of statin in acute coronary syndrome. As already alluded to, it improves endothelial function. It also increases nitric oxide bioactivity, and it reduces reactive oxygen species. And also it reduces all inflammatory markers. As a result, it stabilizes the plaque. So this is how it improves the endothelial function. It reduces the expression of addition molecules such as E-selectin and VCAM and ICAM. It improves the plaque stability. So rosuvastatin improves the plaque stabilization in ACS. This is a head-to-head trial comparing rosuvastatin 20 milligram versus atorvastatin 40 milligram for a period of 12 months. And they were measuring the atheroma volume by intravascular ultrasound, and the volume reduction, the atheroma volume reduction was more with rosuvastatin than the atorvastatin, again emphasizing rosuvastatin is most potent than atorvastatin. So what is the effect of statin on some of these adhesive parameters? MCP1 and IL-6 and IL-8, they are basically cytokine inflammatory markers. There is also a significant reduction with rosuvastatin compared to atorvastatin. What is the effect of statin on high sensitive CRP levels? So it's a very interesting data here. For the same level of LDL cholesterol, one with high CRP and another group with low CRP, that is CRP less than 2 in one group, and another subset, there was a same LDL of more than 70, but CRP was more. And the group, where there was a significant reduction in the vascular event was that group where LDL was low, so also CRP. So because statin reduces both LDL as well as CRP also. Statins to some extent inhibits the platelet activation and aggregation. Of course, it's not a antiplatelet drug by choice, but it has some marginal modest antiplatelet effect. So what is the statin therapy in acute coronary syndrome perspectives in clinical practice? We discussed about the pathophysiologic cascade and what are the actions of statins in atherosclerosis. Now coming to acute coronary syndrome proper. So issue is whether what should be the intensity of statin therapy in ACS, high intensity or it should be low intensity. Another frequently question and also the frequent problem that is encountered to all treating physicians is how long you should continue this. There is no definite answer how long this high dose statin therapy has to be continued, and whether it should be early or whether it should be late. When you are contemplating a PCI, whether it should be given prior to angioplasty, whether it should be given following angioplasty. These are some of the important key consideration whenever you are thinking of statin in ACS. Definitely it should be given early, and also it should be given in high dose, and definitely it should be given prior to PCI for significant benefits. So this is just I am taking back to these definitions of high, moderate and low intensity statin therapy, and we call it as high intensity therapy when we are reducing the LDL reduction by more than 50% on the existing pre-treatment value. When the LDL reduction is between 30 to 49, then we call it as moderate intensity statin therapy. And when target is less than 30% of LDL reduction, it is low intensity. So the dose advocated for high intensity therapy is atorvastatin 40 to 80 and rosuvastatin 20 to 40. And for moderate intensity, it is 10 to 20 milligram of atorvastatin and 5 to 10 milligram of rosuvastatin. And simvastatin, of course, has a low effect. High versus moderate intensive statin here, you can see here it always favors a high intensity statin therapy, because if you look at the various adverse vascular events, even all-cause mortality was 3.4% in high intensity group, and mortality was nearly 4.6% in less intensity group, favoring high intensity or high dose statin therapy. So this bar diagram also depicts the same thing. And what is the effect of high intensity statin when high dose statin is preloaded in patients undergoing PCI for ST elevation MI? It's very interesting. Those who have received high dose of statin prior to primary PCI, they had a very good flow. TME3 flow means it's almost a normal flow, a brisk flow in the culprit artery in nearly 80% of the cases, while with a low dose, it was only 60%. So it improves it's all attributable to better improved endothelial function as well as microvascular dysfunction. So also the myocardial blush was also better in high dose, I mean those who are pre-treated with statin than who are not. So that again emphasizes that statin ST elevation MI patients or non-ST elevation MI patient prior to PCI, they should be pre-treated with high dose of statin, because again I emphasize it's not just epicardial flow that is important, the microvascular flow is also equally important for the better outcome. So if you look at the incidence of death from any cause or a major cardiovascular event with atorvastatin 80 milligram, this is one of the landmark earlier trial, prove it TME 22. So those treated with 80 milligram of atorvastatin, the vascular events were less compared to those with 40 milligram, favoring a high dose of statin therapy in acute coronary syndrome. So these are the benefits of early statin therapy. It's not just In fact, some people ask us, my LDL cholesterol is only 100 or LDL cholesterol is only 90. Should I take high dose statin in a context of ACS? Yes. Despite LDL being as less as 90, even 80 at the time of ACS, high dose statin is recommended because it's not just for LDL cholesterol, it is for plaque stabilization and also to improve the endothelial function. This is the effect of early intense statin therapy on ACS. Again, a meta-analysis of randomized controlled trials. High dose statin, you can see here, the event-free survival was better with high dose statin compared to less intensity group. So again, the miracle study, early statin initiation reduces risk, recurrent ischemic events. So all these trials are consistent in their conclusion that high dose statin and pre-treated with statin and statin started early have got an early benefit. So statin therapy in ACS perspective clinic, what should be the intensity that I already said. Another advantages of pre-treating with high dose statin is the pre-PCI, it reduces myocardial damage during the procedure and also the vascular events also less. This is an interesting picture here. So patient undergoes stenting and there can be a plaque. You are only, of course, you are covering the stenotic lesion, the tightest portion of the lesion, and there can be a plaque above the, well above the stented segment. There can also be a plaque well below the stented segment. When these patients are on high dose statin, when suppose if these plaques, very unstable plaques which are not seen angiographically, if they rupture, there can be an acute myocardial infarction. Either it can happen a month later or can occur even 6 months down the line. So not necessarily it could be a stent thrombosis. It could be due to the rupture of the plaques which are just well above the or well below the stented segment. This is where high dose statin reduces the infarction, even in patients who have undergone stenting. Statin pretreatment in PCI meta-analysis, there is a reduced peri-procedural MI with high dose statin. This I already alluded to. Rosuvastatin versus atorvastatin in post-contrast acute kidney injury in patients. So this is also an interesting data. Those who are pre-treated with high dose statin, of course, it is not statistically significant, but there is some kidney protection in those patients who are treated with high dose statins, pre-treated with high dose statins. So what does guideline says? As far as ESC guideline, it is recommended to start high intensity statin therapy as early as possible unless contraindicated and maintain it long term. So they do not define what should be the duration of high dose statin, but they have recommended that it should be given for a longer time. It is class 1A indication. So also STEMI ACS Europe ESC 2017 also voices the same thing, that it is a class 1A indication. Then coming to ESC EAS recommendations is high risk patients with ACS, it's also a class 1 indication. So LDL reduction in clinical atherosclerotic cardiovascular disease, we all know that you have to maintain high intensity statin because it's going to be a secondary prevention, or it should be high intensity or it should be maximally tolerated statin therapy. More LDL reduction, greater will be the subsequent risk reduction. Use a maximally tolerated statin to lower the LDLs by more 50% or more than 50%. These are secondary prevention in clinical atherosclerotic cardiovascular disease. This is usual algorithm given for that. Suppose if they are not at very high risk, then age more than 70, the dose, it becomes a class 2 indication, high statin. Age less than 75, high intensity statin. That means our LDL goal should be reduction should be at least by 50%. It's a class 1 indication. If high intensity statin not tolerated, use moderate intensity statin, that is also a class 1 indication. And if on maximal statin, if LDL is not still coming down below 70, add ezetimibe. This is class 2B indication. Then, of course, under very high risk category, if clinically, if LDL is not coming down below 70, despite adding ezetimibe, then is PCSK is the option. So these are very high risk for future atherosclerotic cardiovascular events. That is very high risk. What is the definition? History of multiple major atherosclerotic cardiovascular events or one major vascular event plus multiple high risk conditions. So that makes the definition of high risk. So one major coronary event with multiple risk conditions. So that qualifies for high risk category. What are those? One is acute coronary syndrome. This we have discussed. History of ischemic stroke, history of myocardial infarction, other than recent acute coronary. That means history of previous MI plus recent MI. Symptomatic peripheral arterial disease are those who undergone peripheral revascularization or amputation. And high risk conditions, one is history of prior CABG or PCI, familial hypercholesteremia, diabetes, hypertension, and chronic kidney disease. I think diabetes and CKD are extremely important things because any vascular event with this diabetes and hypertension, CKD, they need high intensity statin straight away because CKD and diabetes are almost like an ischemic heart disease equivalent and persistently elevated LDL more than 100 and history of heart failure. So to summarize, acute coronary syndrome is the most common cause of mortality among the cardiovascular diseases. ACS is associated with endothelial dysfunction and vascular inflammation and thrombotic state. Statin improves endothelial function and it stabilizes the plaque, reduces the inflammatory markers like high sensitive CRP, ICAM and VCAM, and early high intensity statin therapy in ACS reduces cardiovascular events. Use of statin prior to PCI helps in reducing post-procedural or peri-procedural myocardial damage and also reduces the adverse events. Thank you, sir.
Thank you very much, Professor Manjunath. I think it was a brilliant talk and you highlighted very well every aspect of coronary artery syndrome, how statins are having a lipid lowering as well as anti-inflammatory as well as minor antithrombotic effects. And I think you have very rightly emphasized the role of rosuvastatin is superior as compared to atorvastatin so far as the lipid volume is concerned. And it is the atheroma volume which is reduced to a greater extent as compared to atorvastatin. Maybe if you use a higher dose of atorvastatin, you may match rosuvastatin. That's the only thing I think we can say. And I think one point you mentioned very categorically that we do not know how long should we continue the high dose. I think that's a very important message we take from the talk. And I think with this, we go to the next presentation and we'll have the discussion in the end. Now, the next speaker is Dr. A.K. Pancholia. I've already introduced to you, and he's covering on a very important subject, and that is statin intolerance. Is it really a problem? What's the benefit which we see by the statins, as mentioned by our previous speakers? Which statin to use, when to use, and for how long to use? Ladies and gentlemen, I present to you Dr. A.K. Pancholia. Dr. Pancholia, sir.
Yeah. Thank you, Dr. Chopra, for the kind invitation and kind introduction. And it is indeed a great honor to share the platform with the two stalwarts in the cardiology, Dr. Manjunath and Dr. Teni Nair. My talk is having two parts. Statin intolerance, is it a real problem versus benefits of the statin? And which statin, when and how long to be given? Now, coming first to the benefits versus risk. The statin benefits, what we see, the meta-analysis of the statin trials showed that each LDL reduction by 39 milligram per deciliter reduced the major cardiovascular events by 23%. And these are the statin benefit trials in the primary prevention, in the secondary prevention, in the acute coronary syndrome also. With the primary prevention trials in diabetes, we have data from the ASCOT-LLA trial with reduction in the risk by 23%. In CARDS trial, there is reduction by 37%. And in heart protection study, there is reduction by 33%. Primary prevention trials in hypertension in the high risk group, we have data from the ASCOT-LLA trial with the primary reduction in primary endpoint reduction by 36% and secondary endpoint 27% reduction. While in the intermediate risk group, we have data from the HOPE-3 trial where the rosuvastatin clearly showed the benefit when it is added to candesartan and hydrochlorothiazide. And these are the secondary prevention trial. The 4A scare lipid crease HPS and PROSPER trial clearly showed a reduction by 15 to 48% in different trials. Statin benefit also seen in stable coronary artery disease. We have data from the TNT trial with reduction in the CHD death, non-fatal MI, and stroke. And we have data from the ACS trials, as Dr. Manjunath already pointed out, the PROVE trial and the MIRACLE trial, where the high dose atorvastatin clearly showed the benefit. Statin benefit also seen when it is given before going to PCI, as we have data from ARMIDA ACS trial and the ARMIDA recapture trials, which clearly showed the benefits. And statin benefit also seen in the secondary prevention of the stroke, as we have data from the SPARKLE trial, where the risk reduction by 20% with a high dose of atorvastatin. Apart from that, it is also useful in peripheral artery disease. Statin therapy is associated with the reduction in amputation and mortality compared to no statin. So overall, we have seen benefits of statin in all the vascular events. Now looking at the other side of the coin, and the issue is statin intolerance. Statin intolerance is defined as the occurrence of myalgia or the other adverse symptoms that are attributed to statin therapy and that lead to discontinuation. But statin intolerance is still debatable, controversial, and there are various opinions regarding the statin intolerance. And this is 2015 American College of Cardiology, the expert analysis about the statin intolerance, which showed that it is not a myth. Statin intolerance is a real phenomenon which might affect up to 15% of the patients treated with statins. In the same year, we had this European Atherosclerotic Society Consensus Panel statement in European Heart Journal, which avoids the use the term statin intolerance, as it is not specific for SAMs, that is statin associated muscle symptoms, and might create a negative impression. In 2016, again European Heart Journal, and this is the paper that negative statin related news stories decrease the statin persistence and increase myocardial infarction and cardiovascular mortality. Premature discontinuation of statin was increased by 9% among those exposed to negative statin related news stories. Conversely, positive statin related news was tied to an 8% low risk of discontinuation, and those who stopped statin had a 26% increased risk of myocardial infarction and 18% increased risk of cardiovascular mortality versus those who continued the therapy. And this is in 2017 in the JAC, that is the editorial comment by Steve Nissen, that on one side of the controversy are the several prominent academic clinical trialists who emphatically assert that intolerance to statin is a rare phenomenon and mostly psychosomatic disorder. And this is from American Heart Association in 2019. The nocebo effect is statin toxicity all the mind, caused by the negative expectations about the effects of treatment because of information provided by clinicians, drug package inserts, media, and the patient's own internet searches about the possible side effects leading to higher than the expected adverse events reporting. And this is the latest on 13th of July 2020, European Heart Journal, Statin Intolerance Myths and Facts. Statin associated muscle symptoms remains a highly controversial topic. Patients frequently complain about the muscle symptoms that they associate with the statin treatment, while the larger randomized statin trials do not report more frequent muscle symptoms compared with placebo. But anyway, the statin-related muscle symptoms or the intolerance is there to some extent, but the benefit outweighs the risks. Patients should be reassured of the benefit of statin in cardiovascular disease prevention. And this is the latest paper by Hoppel and group in the European Heart Journal. Patients on, and that made the things very easy, that the patient on statin with elevated CK levels should be monitored, and patient without CK elevation should be encouraged to continue taking their statin therapy. Thus, the first step in approaching patients with adverse symptoms during the course of statin therapy is identification of those patients for whom the statin intolerance is unlikely. Adverse events which are there for the good supportive evidence are the myopathy, increase in liver function, increase in liver function enzymes, and the new onset diabetes, while the adverse events for which there is little or no supportive evidence are there, like cancer, intracellular hemorrhage, cognitive decline, and so many others. The same prevalence in the clinical practice is 10 to 15%, while in randomized control trial it is less than 5%, and this difference is because the majority of the patients who have muscle-related symptoms are excluded in the randomized control trials. The major symptoms are myalgia, 1.5 to 3%, myopathy, 5 per 1 lakh population, and rhabdomyolysis, 1.6 per 1 lakh population. The risk of muscle symptoms with the individual statins, as from the PRIMO study, it is more with atorvastatin and simvastatin, 14.9 and 18.2%, compared to fluvastatin and pravastatin. And these are the mechanisms of SAMs. Possible mechanisms: increased sarcoplasmic calcium, reduction in the protein synthesis, skeletal muscle dysfunction, and membranolysis. And these are the predisposing factors for the statin intolerance. On the left side, the endogenous factors intrinsic to the patients, like older age, female sex, Asian ethnicity, severe renal dysfunction, acute hepatic disease, hypothyroidism, diabetes, and genetic polymorphism. And on the right side, the modifiable exogenous factors like high dose statin, alcohol abuse, illicit drugs, and drug-drug interactions. Liver injury is very rare. Asymptomatic elevation of transaminases 0.1 to 3%. Clinically significant acute liver injury very rare. And fulminant hepatic failure is extremely rare. And it is all dose dependent and are usually reversed with the lowering of the statin dose. Now, next issue is the statin and diabetes. All the trials with the statin, with the different statins, clearly showed a slight increase in the new onset diabetes, and the absolute risk of developing diabetes 0.3 to 0.5%. And it is more often in those who are having some risk factors or having pre-diabetes, for example, having obesity or impaired fasting glucose or elevated triglyceride and HDL ratio. Incidence diabetes is more with the high intensity statin compared to the moderate or the low potency statin, but the benefits outweighs the risk. As the new onset diabetes, there is a one additional case of diabetes per 255 patients treated for 4 years. The statin treatment, in fact, prevented 5.4 vascular events in these 255 patients. So benefit of statin treatment exceeds. And these are the mechanisms of how statins are responsible for reducing the insulin secretion and reducing the insulin sensitivity. Coming to the clinical evaluation of statin myopathy, National Lipid Association has come out as a very easy task, the SAMS clinical index for evaluation, and come out with the 4 important areas: the regional distribution and pattern of the muscle symptoms, temporal pattern, the challenge, and the challenge. And with the scoring system, the SAMS most probable when the score is 9 to 11, possible SAMS when its score is 7 to 8, and unlikely when the score is less than 7. And this is more easy to evaluate. The SAMS more likely when it is bilateral, large muscle groups are involved, onset 4 to 6 weeks after statin initiation, and onset after the statin dose increase, and when you have the risk factors which I already narrated to you before. How to identify? By checking the CK enzyme levels more than 10 times of upper limit of normal, or hepatic transaminases more than 3 times of the normal levels. Coming to the prevention of statin intolerance, by pre-treatment assessment to assess the risk, the elderly patient, prior muscle symptoms, family history of myopathy, and all those, measure the baseline CK, ALT, and TSH. Counseling of the patient is very important, and monitoring, check the CK and ALT when monitoring the lipid lowering efficacy. And therapy for the statin intolerance are the dietary and the health behavior measures. statin-based strategies, non-statin alternatives and adjuncts, and the treatment targeting the muscle relief like coenzyme Q and vitamin D. Coming to the statin-based therapies, the statin re-challenge, you have to stop the statin for a while, then restart with the lower dose and gradually build up the dose and go up to the upper level. And in the studies, clear showed that 72% of the patients, they tolerate the statin very well when they go for the statin re-challenge. Switching therapy one statin to another statin, the statin, lipophilic statin to be changed to the hydrophilic statin, and cytochrome 450A4 metabolized statin to cytochrome 450 non-3A4 metabolized statin. So the chances of tolerance will be increased. The statin pharmacokinetics, when you look at the rosuvastatin and pitavastatin are hydrophilic statins, and they are not metabolized by 3A4 but metabolized by 2C9, and therefore switching from for example atorvastatin or other statin to rosuvastatin and pitavastatin, then they tolerate it very well. Alternate dose dosing, particularly of those statins who have a longer duration of action like rosuvastatin 19 hours, and the study showed 72% of the patients they tolerated very well with a reduction in LDL by 34%. Once a week statin, again the long duration of statin, long lasting statin, for example rosuvastatin in this particular trial, they showed 2.5 milligram to 20 milligram of rosuvastatin weekly. 74% of the patients they tolerated very well. Statin combination therapy, particularly those statins which are not metabolized by 3A4 and they are more hydrophilic, and when they are combined with ezetimibe, 97% of the patients they tolerated very well. Coming to the non-statin alternatives like ezetimibe, bile acid sequestrants, and ezetimibe and bile acid sequestrant combination. And this is the 2016, the ESC guideline for hypercholesterolemia, which clearly endorsed that in case of statin intolerance, ezetimibe alone or the bile acid sequestrant alone or combination of these ezetimibe and the bile acid sequestrant are considered as a class 2A level C recommendation. Coming to the newer non-statin LD lowering drugs, we have this mipomersan and ApoB synthesis inhibitor, which lowers the LDL in the high risk statin intolerant patients. Another drug is a microsomal triglyceride transfer protein, that is lomitapide that reduces LDL by 70 to 80%. And this is the important breakthrough in statin intolerance, that is a PCSK9 inhibitor. In the GOS2 trial, the evolocumab clearly showed the benefit in these patients when it is given bi-weekly dose or monthly dose with clear reduction in LDL 56 and 52% respectively in statin intolerant patients. And GOS3 also in the same patients, statin intolerant patient again showed the same benefit. Then another trial with the PCSK9 inhibitor, the ODC alternative trial. Here they used alirocumab in statin intolerant patients compared with atorvastatin and ezetimibe. And alirocumab significantly reduced the LDL from baseline to the week 24 versus ezetimibe. And when you look at GOS2 and the ODC trial together, 96 to 95% of the patients they tolerate very well respectively. Another drug is the bempedoic acid, which actually promotes the LDL receptor upregulation. And in statin intolerant patients, the bempedoic acid clearly showed the benefit with reduction in LDL by 23.6%. So non-statin therapy, which I already mentioned to you, should be considered to be an alternative to evidence-based statin therapy only after optimizing the statin therapy and after systemic evaluation of statin intolerance. Coming to the role of complementary therapies in statin intolerance, there are data from the nutraceutical in the statin intolerant patients, and the European guideline 2016 clearly endorsed the role of purified red yeast rice, which may be considered in people with elevated plasma cholesterol concentration who do not qualify for the treatment with the statin in view of their global cardiovascular risks. Coenzyme Q, the studies do not show any beneficial effects in the different trials, while vitamin D also modest improvement is there in couple of trials. And this is algorithm for the statin-induced myopathy. When the CK is not elevated, then discontinue the statin and restart when the free of symptoms is there, while when the CK enzyme is less than 10 times upper limit of normal, then discontinue the statin and consider the precipitating factors like thyroid, exercise, and drug interactions, and then restart the statin with the lower dose and use statin with the less chances of statin associated muscle symptoms to be started. And when the CK levels more than 10 times upper limit of normal, then discontinue the statin and consider the precipitating factors. And again, you have to go in the same way, restart the statin in the lower dose, and those who do not are responsible for the SAMs. So the approach to the patients with the statin intolerance: initiate or intensify the lifestyle changes, reduce the statin dose, re-challenge the statin, reduce the dose and combine with ezetimibe, alternate day or the weekly statin, switch to other statin, and use non-statin drugs like ezetimibe, bile acid suppressants, PCSK9 inhibitors, and bempedoic acid. Check D3 and coenzyme Q. So take away, so for the statin intolerance concern, given the benefits of statins, clinicians should partner with their patients to obtain a proper history and to determine whether they are truly statin intolerant. SAMs may occur, but true statin intolerance is uncommon. SAMs may be managed carefully, which I already described to you. Now I'm coming to my next part of the talk, that is which statin, when and how long to be given. There are challenges with the statin selection, the challenge with achieving the desired lipid levels, challenge in complex medical histories and polymorphism, challenge in patient adherence and tolerability, and challenge in potential statin drug interactions. But based on the clinical trial data, the selection could be for the LDL reduction is already discussed by Dr. Manjunath and others. Rosuvastatin and atorvastatin are the most potent, followed by simvastatin and rovastatin, and it is based on the STELLAR trial. Is a head-to-head comparison of the statins and clearly showed the benefit in favor of rosuvastatin and atorvastatin, more with rosuvastatin. In case of statin-associated muscle symptoms, avoid the most lipophilic statins like lovastatin, atorvastatin, and simvastatin in favor of more hydrophilic statins like clovastatin, pravastatin, and rosuvastatin. As you can see here, rosuvastatin and pitavastatin are more hydrophilic. And statin selection aim to reduce the new onset diabetes, which is an important issue. And as I said earlier, all the trials with the different statins clearly showed slight increase in the risk of new onset diabetes with the statins. And in the Jupiter trial with rosuvastatin with odds ratio of 1.26. And this is the paper by Kaushik Ray. This is a review article, in fact, in the Cardiovascular Diabetology by Kaushik Ray, and which he enrolls that some statins like atorvastatin are associated with increased HbA1c. Other statins like pitavastatin have demonstrated a neutral or the favorable effects on the glucose control in patients with and without type 2 diabetes or metabolic syndrome. Coming to the issue of statin in chronic kidney disease, based on the PLANET trial, the PLANET 1 trial with the statin, PLANET 1 trial in the non-diabetic patients, and the PLANET 2 trial, the diabetic patients, and the summary results clearly showed that any renal adverse events are more with the high dose rosuvastatin compared to high dose of atorvastatin. Acute renal failure, serum creatinine doubling, and serum creatinine doubling or the acute renal failure, again more with the high dose of rosuvastatin compared with high dose atorvastatin. And apart from that, atorvastatin reduces the proteinuria, not rosuvastatin. So based on the PLANET 1 and the PLANET 2 trials, atorvastatin is safer than rosuvastatin in chronic kidney disease. Coming to the statin selection in patients with HIV infection, as you know, majority of the patients, they are on the antiviral drugs, particularly the protease inhibitors, and there are high chances of drug-drug interactions with the statins. So from this, I concluded that the rosuvastatin to be given in the reduced dose in these patients, pitavastatin no dose adjustment is required, atorvastatin to be avoided, and simvastatin is contraindicated. Now coming to the statins in primary prevention of coronary artery disease in diabetes, based on the CARDS trial, atorvastatin should be the choice. Now the question comes, why not rosuvastatin in primary prevention in diabetes? Now the data from the Jupiter, in fact in the Jupiter trial with rosuvastatin, diabetes was one of the exclusion criteria. They are not included diabetic patients. Therefore, the outcome benefits observed with the rosuvastatin in Jupiter study may not be considered as outcome benefit in diabetic population. Statin in primary prevention of coronary artery disease in hypertension in the high risk group, as you see the data from the ESCOT trial in high risk group, atorvastatin may be the choice in these patients, while in the intermediate risk group, based on the HOPE-3 trial, rosuvastatin may be the choice in these patients. Statin in acute coronary syndrome, which I already discussed, based on the PROVE-IT trial and the MIRACLE trial, high dose atorvastatin is the choice in acute coronary syndrome. Secondary prevention after stroke, based on the SPARKLE data, atorvastatin is the choice. And last slide of my talk is statin how long, and I will answer in a single slide, and that is statin treatment is a lifelong commitment, as noted by Dr. Paul Ritker. Thank you very much.
Thank you very much, Dr. Pancholia. I think it was a brilliant talk. You covered every aspect very beautifully. I think statin intolerance, you mentioned so nicely, and about the various types of statin and superiority of one over the other. And I think you mentioned very clear distinction between atorvastatin and rosuvastatin in reference to a renal disease. Before we just interact with the questions, are total about 15. I just have one important question to ask Dr. Pancholia. You mentioned about rosuvastatin, and of course your conclusion was that the atorvastatin is superior in ACS as compared to rosuvastatin. And you also mentioned that rosuvastatin has more renal injury as compared to atorvastatin. I have only one question. If you see the statin intolerance, since you mentioned that the rosuvastatin is more potent, do you see or is there any data to show that the statin intolerance is more with the rosuvastatin as compared to atorvastatin, or there is no data?
No, potency is there, but as I already mentioned in my slide, it is not metabolized through cytochrome 453A4. As majority of the drugs are actually metabolized through this pathway, and there are more of drug-drug interactions. So the less drug interactions will be there with the rosuvastatin, and secondly, it is more hydrophilic than lipophilic. So atorvastatin is more lipophilic. So chances of statin intolerance is more with atorvastatin, and the PRIMO trial I already mentioned, there are increased chances of statin associated muscle symptoms with atorvastatin. So
is there any data on the estimation of CPK enzyme of rosuvastatin versus atorvastatin to substantiate what you're saying?
Not related to the CK enzymes, but based on its metabolism and its lipophilicity or the hydrophilicity, it is based on those trials. And the PRIMO trial and one STORM trial, which also showed more with the atorvastatin.
Anyway, I think it was a brilliant talk, very informative, very educative, and it was a very outstanding, and a lot of information was there. We have about, I think, in the chat box. Let's open the chat box. I think the first question is by Malti Malhotra from Delhi. And she says, if a patient collapses suddenly with MI and transferred to the hospital in a challenging state, and in what form can ecosprin, clopidogrel, or statin be given immediately? And what patient more prone to unstable plaques? So I think the question is referred to Dr. Manjunath. In ACS, the patient comes, which statin is of your first choice and first recommendation when a patient comes in a collapse stat in the emergency?
Yeah, regarding C, it has to be high dose statin. There is nothing to choose because initially either you can give 20 to 40 milligram of rosuvastatin, or you can give 40 to 80 milligram of atorvastatin. But many trials, recent trials have shown that probably rosuvastatin is a little superior to atorvastatin. So high intensity statin, either of the two can be given, along with, of course, aspirin and loading dose of clopidogrel.
Thank you very much.
May I add one thing?
Yeah, please.
Because the hard endpoint data trials are not there with the rosuvastatin. There are two trials, the LUNA trial and the Centaurus trial with the rosuvastatin in acute coronary syndrome. They are actually targeting the lipid parameters and the HSCRP. Not the hard outcome data points are there, what we see in the Prove It To Me 20 and the Miracle trial.
Thank you very much, Dr. Pancholia. There's one more question by Dr. N.K. Sharma from Jalandhar. This is referred to Dr. Pancholia. Should statin be given to all hypertensive patients who has a little bit of dyslipidemia? Is there any adverse effect of statins if given to diabetic patients?
Well, as I already pointed out, in the high risk group, the patient having hypertension and other multiple cardiovascular risk factors 3 or 4, then based on the ESCORT trial, you have to give statin and that shows the benefit. Similarly, in the intermediate risk group, if a patient is having hypertension and only one other associated risk factors like tobacco smoking, overweight, and other factors, then based on the HOPE-3 trial, you have to give statin and that shows the benefit. So in hypertensive patients, based on the risk factors, you have to give statin definitely. And in diabetic patients, the primary prevention, as I already showed the data from the CARDS trial and heart protection study and the ESCORT trial. And in the secondary prevention with the diabetes, we have a couple of more trials. So all diabetic patients should be on statin therapy as recommended by ADA and as recommended by ACC AHA.
Okay. Yeah. Thank you very much, Dr. Pancholia. I think another question to Dr.
Once again, with respect to the statin therapy for hypertension, yes, as Dr. Pancholia said, if hypertension has got one more additional comorbidity, risk factors like smoking or proteinuria and all, yes, they have to be given. And now another interesting, observation is we can do a coronary calcium score. If coronary calcium score is more than 100 Augustin unit, probably we have to give statin, despite LDL being marginally high or being normal.
Thank you very much, Dr. Manjunath. One more question, Dr. A.P. Yadav from Varanasi. I think this question is to Dr. Manjunath again. What do you prefer, sir? Atorvastatin 80 milligrams or rosuvastatin 20 milligrams?
No, actually, preference, it's basically data is in favor of both. Of course, the long-term data is with atorvastatin. Most places only atorvastatin is given, but in some places even 20 to 40 milligram of rosuvastatin is also given. So in most places atorvastatin, but in some people give even rosuvastatin also. But my first choice is for atorvastatin.
It's very clear now.
There is one Indian study very recently, Dr. Devrat Roy and the group, they have come out with the results of one of the study, high dose atorvastatin and high dose rosuvastatin in acute coronary syndrome, and what they found that efficacy wise both are same, but that is highly sensitive C-reactive protein reduction was more observed in the atorvastatin arm than the rosuvastatin arm, and atorvastatin was more tolerated as compared to rosuvastatin in these patients. It's a very recent study by Devrat Roy, Indian study.
Important point. We're just endorsing what Dr. Manjunath just said, that the atorvastatin is definitely superior in the rosuvastatin from every point of view. It's very well tolerated. And as you mentioned about the effect on the CRP levels is also better with the atorvastatin as compared to rosuvastatin. In continuation, Dr. A.P. Yadav has again asked another question to Dr. Manjunath. Probably, what should be the duration of high dose statin? I know you replied that it is not known, but still he's asking this question. What is your recommendation, sir?
Yeah. So actually, of course, there is no clear-cut, guideline how long this high-dose statin has to be continued. But in clinical practice, normally we continue high-dose statin for about 6 months. At the end of 6 months or 6 months to 9 months, then we follow with in the LDL. So because it is a high-risk category, those who have already suffered an ACS or undergone a procedure, and LDL has to be In fact, should be brought down to around 50. That is present recommendation. Of course, less than 70 and preferably 50. So the dose maximally, the dose that maintains LDL around 50 to 70 should be the dose to be continued beyond 6 to 9 months. So irrespective of the even LDL, if it's coming down drastically, many times we have seen with atorvastatin 80 milligram, LDL can be as low as 20 milligrams. It comes down so drastically for some people. So at least for minimum 6 to 9 months, you have to continue high dose statins, and beyond 9 months, probably you have to follow the LDL target guideline.
One question.
I read in one of the article, they said high intensity statin after acute coronary syndrome to be continued for at least 5 years. Although it is not mentioned in any of the guideline.
I think we will go with Dr. Manjunath's recommendation, which is more practical. Studies may be there. One more question, Dr. Pancholia. I think this is from Mumbai for you. What is your clinical experience on statin use and impaired sugar in view of we commonly prescribe statins and beta blocker together in ischemic heart disease?
Well, we're not studied actually, but based on the data, all the statins are responsible for the new onset diabetes, particularly when it is given in those patients who are already having some evidence of a pre-diabetes. So those risk patients, we have to be very careful. But as a whole, the benefit outweighs the risk, which I already clearly mentioned. If the patient is having pre-diabetes and suffered from acute coronary syndrome, though atorvastatin and rosuvastatin are responsible for the new onset diabetes, we have to give those statins definitely, not to go for the pitavastatin, which show the benefit, because we don't have any data of pitavastatin in acute coronary syndrome. So benefit we have to take into consideration.
Even in Jupiter trial, where rosuvastatin is used and the effect on the prevalence of diabetes was concerned, I mean, only 1.8% developed diabetes in the rosuvastatin group and 1.2% in the placebo group. It's not statistically.
It is not. Yes, it is not.
So in fact, it is being overread actually. So those who are already pre-diabetic or a tendency to have diabetes, in them it has caused, abnormal glucose intolerance. But otherwise, statistically, the statin do not significantly increase the incidence of diabetes.
There's one very nice comment given by one of our audience, Dr. Arvind Kumar from Bharat. This type of session which you have done today is very, very useful with a very eminent faculty. I think this is something very good. People are happy that these are very, very need-based discussions. I think the last question now is again from Mumbai for Dr. Manjunath. And the question is, same, I think indirectly, sir, in your practice, when will you decrease the dose of statin, which you already mentioned after 9 months from high dose? You want to say anything else? Any other point, Dr. Manjunath?
Yeah, I think probably same thing applies.
I think with this we close the discussion, and I will just say in my concluding remarks that all the three speakers had a brainstorming session, and the presentation right from Dr. Tiny Nair on remnant cholesterol was outstanding, something new we all have learned, and we have to take a cognizance of this. Importance of total cholesterol, triglycerides, chylomicron, and how do we estimate the remnant cholesterol, and I think the efficacy of statins in reduction of remnant cholesterol is very, very important to mention. Dr. Manjunath did a very good job because ACS is a burning topic, and I think he simplified with best possible methods of practical application, and I think the message has been very clearly mentioned that the atorvastatin practices more as compared to rosuvastatin, but rosuvastatin can also be given. And I think most of our patients who come with the comorbidity in the elderly And if they have an underlying CKD, we have to be very careful, as mentioned by Dr. Pancholia. I think this is a very, very important message, which we must consider before choosing atorva versus rozova. The second important point, I think, was very rightly mentioned by Dr. Manjunath, that the duration of therapy of a high dose should be minimum for 9 months. And I think that's more practical approach. And subsequently, you can reduce, and depends on patient to patient. But this is just in general a guideline which we must consider, and I think is very, very important. High the statin intolerance, as mentioned by Dr. Pancholia, has been a very controversial subject. And he used a very nice slide to show the benefit versus risk. If the benefits are more, I think the risk is undermined. We should see which patient benefits more. Intolerance can be taken care of, and you mentioned about 2 or 3 things about the Q enzyme. I think you mentioned very rightly there is not much data to support. Told of vitamin D and red rice or something like that. I think we need to have more data to show the effect. You also mentioned about PCSK9. I think there's a lot of data people are working now, especially after the CVD. Patient undergo PCI, and if they have a high levels of dyslipidemia, so they give a combination along with the atorvastatin. So this is a very, very important point which people consider, and I think some people are using. I know of 2 or 3 of my patients who underwent intervention by Dr. Viveka Kumar. He is giving PCSK9 in these patients on regular basis. High intensity statin therapy, there is no doubt. I think very rightly mentioned by all the speakers. I think overall it was a very, very educative talk. And I must say from the core of my heart that all the speakers were superb and very, very educative. I thought it may generate less interest, but I think the questions are a lot. Though I have enumerated a few only because of paucity of time. Because Dr. Manjunath also had to go somewhere. He had some meeting, we especially requested him. So once again, on behalf of the national webinar on statin, advances in statin therapy, I express my heartfelt gratitude to all the eminent faculty. And I am very grateful to one person from IPCA, Johnny Edwin, who did a wonderful job in coordinating the event. It was not easy. It's very tough. Everybody is so occupied. I know Dr. Manjunath is very, very busy because of COVID patients, and he had so many meetings, but somehow he could manage it. Dr. Pancholia and Dr. Tain, we are very, very grateful. I'll request Dr. Johnny Edwin, if he's in the audience. In last, I must express my gratitude to all the members of IPCA who really worked very hard. Not only Johnny Edwin, but everyone as a team, because it's a pan-India effort. And I think our audience who had a very nice interaction. Now I hand over the mic to our colleague, Johnny Edwin, to propose a formal vote of thanks. Johnny.
Good evening, sir. Thank you, and good evening, sir. Doctors, in fact, it's a great honor and pleasure to have you all, and our heartfelt thanks to all the participants. We had almost more than 1,600 doctors attending today's webinar. So a heartfelt thanks to each one and all, as well as our indeed a great pleasure to have the doyens in the field of cardiology today with us for this interesting session on statins. And particularly our heartfelt thanks and gratitude to Dr. C. and Padma Shri, Dr. C. and Manjunath for his valuable presence despite a very, very hectic schedule. So we are very, very grateful to you for this, for your valuable time and an excellent contribution. And to know more about